Hello and welcome to the New School OBGYN podcast, a podcast in women's health, but for everyone. Our goal is to promote good, reliable knowledge because the source of your information matters. My name is Eric Schmidt. I'm a board-certified OBGYN, and today I have with me again, Ms. Taryn Miyaoka.
Hi.
Mrs. Sorry.
Mrs.
Parker. Sorry. Please consider downloading and following along. We're on all the major podcast hosts, and check us out on YouTube. We'll hopefully have a video podcast up soon. And so again, Taryn is one of our physician associates. She did her schooling at University of Washington and Wake Forest for PA school. And we're going to talk about the second trimester and the prenatal visits within the second trimester. Well, if you are someone that's pregnant, congratulations. You've made it through the first trimester. My least favorite trimester. And so hopefully the symptoms of nausea and vomiting are starting to improve. The fatigue is improving, less concerning about things like bleeding and miscarriage. And so generally the second trimester is a nice time. And I'm sure you see that as well, Taryn, in the office. And so the first trimester basically goes into about 13, 14 weeks. And then that's when the second trimester takes over. And we're going to get through some of the nitty gritty of what a lot of the prenatal visits entail. And then we're going to get into sorry, dog is barking. And then we're going to talk a little more about personal experience.
So like you said, second trimester often starts around 14 weeks. Kind of in the earlier second trimester, things that will maybe come up are additional options for genetic screening. So there are some options in the first trimester. You can reference that video if you want to learn more about that. But in the second trimester, we have something called the quad screen that we can do. So this basically checks for like Down syndrome, Edwards syndrome, as well as checking that baby's spinal cord is developing properly. For screening for neural tree defects or spina bifida, again, looking at that spinal cord, we can also do an additional test called an AFP. So that's included in the quad screen. But for someone that maybe did a different type of genetic screening in the first trimester, that's sometimes something we'll add on because that wasn't included initially. And that's usually done between 15 and 20 weeks. And it's just a blood draw for mom, but helps us be reassured that baby doesn't have any issues with their spinal cord. Also, typically around 18 to 22 weeks, we'll get the anatomy ultrasound. It's always a fun one for both sets of parents, and that can always be nice to get another sneak peek at baby. If baby is bigger, you can see more of the anatomy, so you can get some really cute photos of baby, and it's also good for us to be able to see all the different anatomy and kind of be reassured that that looks fairly normal as long as we can see. And then also at that time, we'll start doing fundal height measurements. So typically we're measuring just to see the top of the uterus down kind of to the pubic bone area. And that fundal height we measure in centimeters. It should correlate for the most part to the amount of weeks that you are. So if you're about 24 weeks, then you should be around 24 centimeters, give or take a little bit. And usually you'll start that around 24 weeks as well. It's a very gross measurement of a baby's weight. So if baby's measuring very small or potentially really big, it might trigger us to get an ultrasound to check on baby's growth. But I don't typically give estimated fetal weights off of that because one, I'm not very good at it, and two, I don't think it's very accurate.
You're good at it. So it's a very rough estimate. We generally say that if the uterus, the fundus, or we might say, is up to the belly button, that is around 20 weeks pregnant. And so measuring above that 1 centimeter per week, give or take. If there is a centimeter or two off, we generally consider that normal, as long as it's consistent. But if it suddenly jumps one way or the other, it would definitely trigger us to look closer with ultrasound. And ultrasound nowadays is generally a better measurement to see if there's any issues with baby's growth or fluid development. And again, those issues aren't really going to happen in the first trimester or even an early second trimester. That's more of a later second trimester and third trimester issue. And so second trimester is also, it's famous for the anatomy ultrasound, but it's also famous for the screening for the gestational diabetes. And well, why do we do that? Because there are, mind block for a second. A couple hormones in the pregnancy that, we talked about in other podcasts that the hormones create laxity in joints, but they also create some insulin resistance. And so blood sugars can be higher. And this doesn't matter if someone is, someone that works out every day, is very careful with their diet, low BMI, it doesn't matter because these hormones can affect the way that the body digests its sugars. And so if that is significant enough, we call it diabetes. And so we test generally around 24 to 28 weeks of the pregnancy, sometimes earlier if there's other risk factors such as gestational diabetes previously, or if someone may be a pre-diabetic to begin with. That also is sometimes we test even in the first trimester. And so how we generally do this in the United States, I think is very similar. There are some differences, but usually we start with a screening test, and we're looking in the broad population, figure out who's at the highest risk. And that's what a screening test does. And so we give 50 grams of a glucose solution, and the patient drinks that. Usually we recommend, drink it within 5 minutes, so you kind of have to drink it fast. And then, excuse me. And then 1 hour later, we want to be drawing your blood to see if it's above or below this threshold. This threshold, again, has some variance, and it might be a little tailored based on each individual patient or the provider preferences. But generally, it's 130 to 140 for the blood sugar on the blood draw. If it's elevated, then we're concerned, okay, this patient might be at increased risk for gestational diabetes, and we want to do additional testing. And the diagnostic test is to do another glucose drink. This time it's 100 grams of glucose, and we test the blood sugar fasting. So to go back, the 1 hour test that we previously talked about, that doesn't have to be fasting. I wouldn't eat a bunch of candies right beforehand, but it doesn't have to be fasting. The 3 hour test, if we want the fasting number, and so have to be fasting for this one. Again, drink, and then we test the blood sugar 1 hour, 2 hours, 3 hours. And if there's multiple elevateds, that's how you meet the diagnosis for gestational diabetes. All right. And so other things we're testing for in that actually the same blood draw, to save blood draws, is screening for anemia or low platelets in the pregnancy, because pregnancy-induced changes can cause this. And as we're getting closer to delivery, we really want to know that these things are within normal range. Otherwise, we might want to start some interventions like iron supplements. And then, this is for specific to mothers that are blood type negative. If they are blood type negative around this time, we're also testing for antibodies, because someone who is blood type negative and has a blood type positive baby is at risk for potentially the body becoming sensitized to that blood type positive baby. And this can happen potentially spontaneously. That's why we give RhoGAM in each pregnancy for Rh negative mothers. But it's also to protect against potential bleeding episodes and potential, because we think that interaction and seeing baby's blood and with mom's immune system will sensitize it and potentially cause complications in future pregnancies, and we do not want that. All right. So the second trimester, it's kind of nice. Not too bad. This is a quicker podcast, but there are a couple things which we start to see, common questions that we have, and that are starting to be pertinent. And so as Taryn starts to talk about these things, I'm gonna give her a nice little drink here, a treat.
Yeah, so some things that I'll touch on with patients are like sleeping positions. So typically, I usually recommend around 20 weeks to try to avoid like laying flat on your back, whether you're exercising, definitely, or if you're sleeping. So trying to sleep on your left or right side. And really the reason behind this is that the uterus, as it gets bigger, has the potential to compress some big blood vessels that are giving blood flow to you as well as to baby. And so we just don't want that to happen. Sometimes people, when they're laying down, if they're flatter than maybe they realize, may have a little bit of lightheadedness or dizziness, or even can feel a little bit nauseous and flushed. If that happens to you, I would try to shift your position and see if that helps, because it might just be that, maybe had a little bit of decreased blood flow to the brain. But also the other thing that comes up a lot of times is people will be sleeping. They start on their left or right side. They wake up in the middle of the night. They realize they're on their back, and that often worries them. Usually this is like no cause for alarm at all. Just turn over to your left or right side and go back to sleep.
So as Taryn was talking, I got us a nice little drink. It is the glucose drink that we're going to sample here on the podcast. It is fruit punch flavored.
Okay.
And so we'll see if we like.
Cheers.
Cheers.
Oh. Wow. Oh, it's bad.
I don't think it's that bad. I think if you drink a lot of it,
I can't imagine drinking all of that for one. And
let's just say it tastes like a flat. I guess fruit punch is already flat, but anyway, it's not too bad.
It does taste like fruit punch, but it's like fruit punch with like extra sugar dropped in. And I think
it gives you gut rot a little bit, but it's not as bad. I've tried the lime one. That one was a little bit better.
Okay.
So if you ever have to take one, I would go with the lime. But to each their own. So sleeping positions is a tough thing because there's the anatomic idea, or that if the growing uterus compresses the blood vessels, specifically vena cava, that could potentially decrease the blood flow to the mom, to the baby, but also it would do it to mom. So generally, if let me say this first. There is some potential, studies, some reviews on this, and it's not very supportive that this actually increases the risks to the pregnancy, to the baby, because what we're worried about is stillbirth, and it's there's this idea that could potentially decrease blood flow, and we're talking about a very serious complication, and so it's, I think, difficult to say, oh, sleep whatever position you want, don't worry about that, because there's this idea that anatomically this could compress the blood vessels and lead to decreased blood flow to mom. And again, mom, so what I tell patients is, if you ever feel like you're short of breath or just don't feel right laying in a position, change your position, whether that's laying on your back, go to your side or the other side, because that could be a compression of the blood vessel. But I often really try to reassure patients that this is not going to cause any serious harm to baby. We say it, we recommend it because of the theoretical idea of it, but I don't want patients really being hard on themselves because they woke up in the middle of the night and they were on their back and they're worried they harmed their baby. This is not true, but we still say, okay, maybe later second trimester, maybe third trimester, start being cognizant of it, especially if like you're laying around during the day and you realize a certain position causes you to be really short of breath. Maybe try to avoid that position, but don't feel like you're going to be doing harm to your baby because of a certain position. And so that's what I generally say, and it's very varied, but it's generally because of the serious idea of a serious consequence. We're careful.
Yeah, that's fair.
Yes, and we're starting to feel fetal movements. This varies, again, based on if it's your first pregnancy or if it's a subsequent pregnancy. And so if someone's telling you they feel fetal movements 16, 18 weeks, and you're sitting there worried, oh, I might not be feeling my baby move, why don't I? Please don't let their unsolicited advice trouble you, because it's different for everyone, and it can be where the placenta is. If the placenta is in front, sometimes that cushions the skin from feeling those kicks early on. And so, really be careful comparing yourself to others. For a first pregnancy, sometimes I say moms might not feel movement beyond 20 weeks, 22 weeks, 24 weeks. And, they'll be getting an anatomy ultrasound around that time, which will reassure both us and the patient that everything is okay. But it might not be until mid-second or late second trimester where you're feeling consistent movement.
Yeah.
You see that too?
Yeah, definitely. Yeah. Definitely with like placenta location too.
Yeah.
Sometimes if I see that a patient has, for example, like an anterior placenta, so placenta in the front, which is totally fine to have, I will sometimes just caution them, like, or give them a heads up, basically. Like, you might hear other people are having movements earlier. It's totally normal, especially in the circumstance, to feel them a little bit later or softer, or sometimes just when you're in certain positions, just because of that cushioning effect that the placenta can have. And sometimes I just like to give them a heads up because it can cause concern when you're hearing, if you're all in these forums and you hear like, oh, I started feeling movement so early, then it's hard not to compare yourself, but try not to.
Yeah. Yeah. GERD starts to become reflux. One of those things, again, you don't have to wait for your provider to, or you should let them know, but you can do things like Tums, but frequent Tums use, or the calcium carbonate, I believe it is, can actually potentially make it worse if you're using that like multiple times per day, because your body reflexes to make more acid. So you might need something like Pepsid, which is more of a directed decrease in the acid versus covering it up.
Yeah. I just say if you're using Tums like throughout the day, you might just want to switch to Pepsid.
Yeah.
If it's just once, or twice, like sure, use Tums, that's great. But yeah, if it's pretty consistent, Pepsid might be a better choice.
All right. Nice and quick, second trimester.
Cool.
Thank you everybody for listening. That's it for today's podcast. Thank you for viewing if you watched on YouTube. As always, the content of this podcast is educational purposes only. None of the content is meant for medical advice. And please contact your medical provider if you need that. All right. Have a good day, everybody.
Bye.